Is Dr. Riddhi Dasgupta. She will address a very relevant topic, the role of C-peptide estimation in the management of diabetes mellitus. Let's welcome Dr. Dasgupta to the podium.
Welcome, Dr. Dasgupta. C-peptide is a marker of endogenous insulin. But what's the clinical relevance of C-peptide? What are the therapeutic relevances of C-peptide? To talk on that, we have Dr. Riddhi Dasgupta, who is a professor of endocrinology at Saptagiri Institute of Medical Science and Research. I hand over the mic to him.
Good afternoon all, and thank you for the kind introduction. Because of my unique name, I'm possibly the only endocrinologist who has had multiple gender reaffirmation techniques over the years. So nothing wrong with that. Today I will talk about C-peptide in diabetes, and I'll be going briefly over the physiology of C-peptide, estimating it in our routine practice, what is the clinical utility, role in prognosis and treatment of diabetes, and a bit about Indian research, which I have been fortunate to be associated with. So as you all know, it's a 31 amino acid peptide with a 1:1 ratio of active insulin to C-peptide, and it's a reliable indicator of endogenous insulin secretion. Of course, a very common question which we used to be asked in our exams is why it is more accurate than insulin. Obviously, it's stable, it undergoes minimal liver metabolism and cleared at a constant rate in the peripheral circulation, and measurement is more consistent. Now, measuring C-peptide, we need to remember certain important points. An ideal assay should have less than 10% cross-reactivity with pro-insulin. Because of its renal metabolism, patients with CKD, it's not a great marker. Large number of anti-insulin antibodies can actually give you a falsely high C-peptide reading. And the most important formula is at the bottom of the slide. Always look at the units. So by and large, Western literature reports it as 1 nanomoles per liter. And our readings are mostly in nanograms per milliliter. So you just need to multiply by 3 if you get a value in nanomoles per liter. So that's very important when you're interpreting C-peptides. These are the common factors known to most of us, most important being the existing blood glucose concentration, the level of incretins, renal function, and of course insulin resistance, which can give you higher C-peptide values. Now, blood sample, ideally it should be collected in EDTA tubes, which is stable for more than 24 hours. If collected in the plain tube, then it is stable for up to 6 hours and it degrades by 24 hours. Again, important if you are sending it to your lab. Assessing insulin secretion. Now, obviously, we have a lot of confusion regarding the methods. Fasting or random sampling or stimulated, these are the 3 most important methods. If your coexistent glucose levels are more than 140 milligrams per deciliter, a random C-peptide is as good as a stimulated C-peptide. So for all practical purposes in clinical settings, you do not need to do an mixed meal test or a glucagon stimulation test if you can maintain glucose levels more than 140. So there is evidence for that. As you can see, the correlation with the gold standard of mixed meal is 0.91. and it improves to 0.96 when you are able to maintain glucose levels more than 140. Not only that, studies have shown that the sensitivity of non-fasting C-peptide was greater at a cutoff of 0.35 nanomoles per liter for identifying patients with autoimmune or type 1 diabetes. All the more reason why you can safely use this in your laboratory. Coming to stimulated testing, which is obviously the gold standard, we have 2 techniques. One is the glucagon. The advantage of the glucagon is that you get your results in 6 minutes. And it is shown to have 2-fold higher stimulation than glucose or use of tolbutamide, which is now largely gone out of use. However, the best test, if you are doing a research or a study on using the C-peptide, would be a mixed meal tolerance test. I have been involved with a large number of studies involving MMTT, and the Ensure powder, the Western literature quotes as Sustacal, which is not available in our country. Mostly Ensure, you need to give a dose of 6 kilocalories per kg. or 6 ml per kg. Each ml has 1 kilocalorie, and 1 scoop of the Ensure powder gives you around 8.9 grams or 36 kilocalorie. And then you need to measure every half an hour up to 120. If you do it up to 180, it's all the more. So this is the gold standard. If you want to do a research publication, this is the method you should go by. The reason being, as you can see, compared to the glucagon test, it gives a much more robust 90 minutes peak, and it has a very good estimation of beta cell secretion. The other test that is often ignored is that of a urine C-peptide. Again, it's a non-invasive way, and if you are collecting the urine C-peptide, it has to be in boric acid, that is for the 24-hour collection. However, a spot urine C-peptide creatinine ratio works just as well, especially if you can do it 2 hours after a post-meal. Studies have shown that it is quite effective in distinguishing type 2 from type 1. So this is another very easily done test, provided you have access to urine C-peptide testing. And these are the studies that have even looked at differentiating MODY using the urine C-peptide creatinine ratio. So this is a brief snapshot of the different methods that I discussed. Majorly, the cutoffs you can see are less than 0.2 nanomoles per liter, which translates to around 0.6 nanograms per milliliters, of which in your routine setting, advisable to do a non-fasting C-peptide with glucose levels more than 140. If you're planning a research study, best is to go for a mixed meal. If time is a constraint, then the second line would be a glucagon stimulation test. Now we come to the clinical utility of C-peptide. Obviously, the most important question is classification of diabetes. And these are the different forms of diabetes which I will go through where C-peptide has been found to have a role. And this does include Indian research also in these aspects. Firstly, between type 1 and type 2. So any patient 3 to 5 years after diagnosis of a possible type 1 lands up with a random C-peptide of less than 0.2 nanomoles per liter, indicates absolute insulin deficiency. If it is less than 0.6, then it is probable type 1 diabetes. So higher values than 0.6, it's very unlikely 5 years after diagnosis that it is a case of type 1 diabetes. However, there is significant diagnostic overlap, and there is a significant honeymoon phase as well in type 1 diabetes, which can kind of give you false results. These are the studies that have looked at differentiating between type 2 and type 1. Once again, you can see largely cutoffs of 0.2 to 0.3 has been taken as having a good predictive value. The other disease often we find in the young diabetes is MODY. Again, a urine C-peptide creatinine ratio of more than 0.2 or a random blood C-peptide ratio of more than 0.2 in someone with diabetes less than 30 years of age, diagnosed more than 3 years after the onset of diabetes. In all probability, you are dealing with MODY. However, it is not very sensitive in differentiating from type 2. Now, this is one of our patients came to OPD with classical osmotic symptoms, no history of ketoacidosis. Antibodies were strongly positive, lean BMI, and C-peptide levels drastically low. Patient started on insulin, subsequently had an improvement, a classical presentation of latent autoimmune diabetes in adult. So again, a very important phenotype where C-peptide is kind of the bedrock for diagnosis. As you can see, it is one of the key differentiating factors from type 2 diabetes. Not only that, the current recommendation for treatment of LADA is entirely based on C-peptide values, and people more than 0.3 to 0.7 nanomoles can very well be treated with oral antidiabetic drugs with close follow-up. Coming to the next type of diabetes, as most of you are aware, is the type 5 diabetes, which I have been fortunate to have worked with at Vellore. And here also we did a wide array of tests to look at the pattern of type 5 diabetes. And what stood out was the significant reduction in insulin secretion rates, which was even lower than the type 2 diabetes, clearly suggesting that it is possibly not just a lean variant of the type 2. We looked at the multiple factors like body fat, clamps, and all, and amongst that, significant insulinopenia with a minimal incretin effect was the defining feature of this disease. Moving on, this was a very interesting patient who came with frank diabetic ketoacidosis, A1Cs of 12, autoantibodies was negative, stimulated C-peptides were in the range of 0.6 nanogram per ml. We started the patient on insulin, had a rapid reduction in insulin requirements over the next 3 to 6 months, so much so that the patient was taken off insulin and started only on oral anti-diabetic drugs. C-peptides jumped to more than 2 nanograms per ml, and the patient on 3-year follow-up continues to maintain normoglycemia on diet and metformin. So this was the first reported patient of KPD or ketosis-prone diabetes from India. We subsequently looked at our data and we found over a period of 1 year, 11 such patients who presented with DKA, and gradually the DKA resolved and had a resolution in the C-peptide level. So this is the first and largest cohort from India, and 25% of your new onset diabetic ketoacidosis may actually be this variant where serial monitoring of C-peptide, as you can see, almost every 3 to 6 months is mandatory to diagnose the condition. Now, as luck would have it, after 4 years, I was working in Calcutta, and there we had this lady. This was during the COVID times, and had a very similar presentation of DKA, suppressed C-peptide. We started on insulin, and gradually this patient also started recovering her C-peptide levels and maintained normoglycemia with a combination of oral antidiabetic drugs. So this is a variant of KPD. Again, this is known as the provoked variant. We looked at the literature, and from China, there were 2 reports of human herpes virus 8 and H1N1 influenza. We went back through our data, and we published this as COVID-19 as a novel etiology for provoked ketosis-prone diabetes. Once again, serial C-peptide level estimations in this patient was key to making the diagnosis. So whenever you're getting a patient of diabetic ketoacidosis, it's important to keep these differentials in mind. Not all DKAs, especially they are antibody negative, necessarily are type 1 diabetes. So that's the message from doing these C-peptide levels. And then we had this study coming out of China where actually 2-hour C-peptide was used as a risk scoring index for predicting the risk of ketosis-prone diabetes, and this involved the Indian cohort as well. A very obvious diagnosis, a 26-year-old male with nyctalopia, along with recurrent episodes of pain abdomen, very low vitamin A levels. Obviously, it's a case of fibrocalcific pancreatic diabetes with WHO grade X2 vitamin A deficiency. Now, we have worked extensively with FCPD during my time at Vellore, and we did a lot of tests, including the mixed meal test, to look at the C-peptide. And as you can see, their C-peptide or insulin secretion levels are almost as low as that of type 1 diabetes. However, that's not a very surprising finding. It's what has been quoted in literature. What was surprising is when we looked at the hypoglycemia unawareness in these people and the glycemic variability, we found 2 important things. One is obviously a proportion of these FCPD have increased glucagon as opposed to the conventional thinking, and that predisposes to improved hypoglycemia awareness. There's also a dichotomy in the C-peptide levels, and a poorer C-peptide reserve actually makes them more prone to glycemic variability and unawareness, again suggesting that FCPD is a heterogeneous disorder, and estimation of C-peptide at the baseline may give you an idea about the long-term risks of hypoglycemia and glycemic control. Most of us have heard about the clusters of diabetes. This is from the Alquist group. Again, if you see the HOMA2 beta, which bases itself on estimation of C-peptide, so that's a key component if you want to classify your patients as per the clusters. Dr. Mohan's publication also, if you see the Indian group, predominantly the severe insulin deficient one, characterized by very low C-peptide levels. And this very nice infographic actually gives you the type of treatment needed for the various clusters of diabetes. And SIDD, which is kind of the commonest in India, has larger rates of neuropathy and retinopathy. Early insulinization and insulin secretagogues may be needed in this population. Again, these are studies which has looked at incorporating C-peptide into novel indices. This is known as Index 60. It is available online as an easily computable tool depending on a 60-minute glucose and a 60-minute C-peptide. And this actually has been shown to be a better marker than 2-hour postprandial glucose or HbA1c for progression to stage 3 in patients with type 1 diabetes. We have also tried looking at Indian data, and one of the indices that we came up with was 20 by fasting C-peptide into plasma glucose, which interestingly performed well as a marker of insulin sensitivity, and it did better than the established markers of Quickie and HOMA-IR. We also looked at incorporating C-peptide into 2 indices, that is the SPINA-DI and the SPINA-CARB, which are mathematical models, again available online, that can give you a composite estimation of insulin sensitivity. So these have been tailored to the Indian population, very similar to the Bergman's model that we have for the Western population. Of course, C-peptide does have a role in detecting absolute insulin deficiency. As I said, it prevents acute hyperglycemic crisis and ensures early insulin initiation. Does it help in treatment response? It may have a role in change in insulin. Mainly once you know that the patient has absolute insulin deficiency, you can switch to insulin. However, larger studies are needed to exactly delineate its role in treatment change. Insulin dependence in KPD or ketosis-prone diabetes, as I already said, in our cohort, those with a stimulated C-peptide of more than 0.8 at 1 year has continued to be free of insulin at 3 to 5 years follow-up. Treatment change in non-insulin treated diabetes or type 2, the data is not that robust. Once again, low levels of less than 0.2 may be an indicator. However, it has a minimal role in guiding treatment with oral anti-diabetic drugs. Glycemic response to bariatric surgery, again, an innovative role. Studies have shown that a preoperative fasting C-peptide of more than 1, or some say more than 2, predicts up to a 90% remission rate for bariatric surgery, especially the restrictive procedures. Can C-peptide help us in determining prognosis of diabetes? This very nice study by Michael Rickels has shown that if you start out with a higher residual C-peptide, you are likely to end up with less complications, better glycemic control, and less risk of hypoglycemia. Studies have also shown correlations with complications in type 2 diabetes. However, the data on that is not yet that robust to suggest it as a routine marker of prognosis in type 2 diabetes. Partial remission phase, as I was talking about, there could be a significant honeymoon phase in type 1 diabetes, and that is where C-peptide may come in play. This landmark study by Shields actually shows a biphasic response to the C-peptide, where there's a drastic fall for the first 7 years after diagnosis in type 1, and after that they tend to plateau out. So it is the initial phase where you have the maximum loss of C-peptide in type 1 diabetes. Islet cell transplants, again, documented C-peptide of less than 0.1 or 0.16 is mandatory to start or to consider a patient for islet cell transplantation. Now, these are 2 studies done around 2014 and 15 where they have looked at the role of C-peptide as a form of therapy. However, because of the inherent problems with stability and long-term stability in the body, this has not been that popular, but there is research going on in this area as well. However, C-peptide has shown to be a strong marker as a validated surrogate in patients with type 1 diabetes, especially in trials of disease-modifying therapies. Now, this is one study which is ongoing at my center where we have blended C-peptide with machine learning because no study nowadays is complete without a bit of AI. So we thought of utilizing machine learning to predict the progression of pancreatitis to type 3C diabetes. This was a retrospective data analysis with at least a 5-year follow-up. We named it as Sankalp. And these were the data that was input into the model, and the initial results have been very encouraging. As you can see, nearly 90% sensitivity and up to 80% specificity in predicting type 3C diabetes following an episode of pancreatitis. And when we did the SHAP analysis, which shows the individual contributions, we found baseline C-peptide to be the most important contributor. So final slide, when to use C-peptide. It is recommended mainly in patients on insulin when diagnosis is uncertain or when therapy depends on residual beta cell function. Non-fasting C-peptide with a glucose maintained of more than 140 is suitable for most clinical settings. Stimulated C-peptide consider only in research settings. Urine C-peptide, if you have access to, can be an important non-invasive test. And this is a snapshot of the important cutoffs that we use based on the different thresholds of C-peptide according to the different tests that are commonly used. Thank you.
Thank you, sir, for that evidence-based and practical overview. The dais is now open for discussion.
How to interpret C-peptide value when somebody is on incretin therapy, because it's already stimulated?
Yes, so the guidelines, the recommendations on that for testing is not very clear, I would say. Ideally, the person should be off that. Again, depends on the duration of action of the incretin therapy. Earlier, it used to say that if it was an insulin secretagogue, then at least a 24 hours gap. If on insulin, depending on the type of insulin. When we did the studies at Vellore, we used to stop the basal insulin for 24 hours, the intermediate one for 12 hours, and the shorter one for 6 hours, and the secretagogues for 24 hours. There's not much data on incretin and how it influences an estimation of C-peptide. Again, depends on the feasibility of the setting. So in a clinical setting, it may not always be possible to stop the drug. So depending on the scenario, you may have to take that into account. If it's for a research purpose, then at least 24 hours based on the half-life of the drug would be advisable.
And while checking for C-peptide, we wait after diagnosis of diabetes for about 2 weeks. Is it important to wait for 2 weeks, or is there any sugar value beyond which we should not test for basal C-peptide?
So yes, so the glucotoxicity has a role on giving a falsely lower value of C-peptide. So the recommendation again is for any hyperglycemic crisis, the waiting period should be 2 weeks. If it's a DKA, a lot of times we see immediately a C-peptide being done. Regarding other patients with hyperglycemia, there's no such upper limit, but most of the studies have avoided people with sugars in excess of 300 or 350. So I would say above 140, but definitely less than 300 should be the target.
If the fasting sugar level is around 160 or 170, it technically is not fasting, it's already a stimulated value. Should we interpret it as a fasting C-peptide or a stimulated C-peptide?
No, we take that as a stimulated. So the studies have shown that it correlates best with stimulated. So once you have a glucose level of more than 140, it is as good as a stimulated value.
So you have to interpret for the normality,
yes,
for stimulated value.
as a stimulated one.